Ankit, should I take it over from here?
Yes, sir. You can go like.
Welcome, friends. Greetings from the American College of Physicians India Chapter to all of you. For last 1 year, you are seeing that we are organizing a number of programs on various diseases, non-communicable as well as communicable diseases on the forum of American College of Physicians. This time, for the first, we are coming up with a program with investigation keeping in the center stage. Very fastly, we know that echocardiography is going to be a routine investigation from the advanced investigation. Earlier, we were considering that it is a very advanced investigation and it's needed to be done in the very elite class or any very serious patients only. But now it has been a need of the basic diagnosis, especially in the patient with diabetes, especially in the patient those who are having high level of the atherosclerotic cardiovascular disease. Keeping all these things in the mind, keeping in the mind that people are coming up with the heart failure, may it be the preserved ejection fraction or non-preserved ejection fraction or both the conditions, we need to do echocardiography to know about what is the status of the people. Dr. Sajid Ansari, who is a practitioner cardiologist in Lucknow, and he is having his inclination towards the 2D echocardiography, and he has organized this program today. He will be moderating this session, and he will be introducing the eminent chairpersons and speakers, Dr. Aditya Kapoor, who is also the advisory council member of the Acp India Chapter, with Dr. Rakesh Gupta, who is the eminent cardiologist of the country, apart from two of the panelists, Dr. Naveen Jamwal and Dr. Akhil Sharma. Dr. Sajid Ansari will give the detailed introduction of these speakers, chairperson, and panelists. Before, I must introduce Dr. Sajid Ansari to all of you. As I said, he is a practitioner cardiologist. He is an upcoming academician who is growing fast in today's time and is having his inclination towards organizing multiple programs. He is going to organize the National Conference of Indian Society of Hypertension, BPCon, this year. And apart from that, his interest is showing that we can see him in near future in such kind of the roles in multiple forums. Acp India Chapter is really feeling proud to have him on his forum. He has been invited FACP this year also, and this will be granted to him in Chicago Annual Conference of the American College of Physicians. With this small introduction, I will hand over the podium to Dr. Sajid Ansari and will request him to take us from here in this program, which has been designed by you. Over to Sajid.
Thank you, sir. Thank you to Dr. Anuj Maheshwari, was governor of Acp India Chapter, and this is my great pride privilege to having organized such a program under this forum. And thank you, boss, for giving this opportunity. For today program, we have eminent speaker Dr. Rakesh Gupta, sir, and I choose the topic and I requested sir to go and say a few things basic about the hemodynamics and how we correlate within their clinical finding day-to-day practice to evaluate the patient. For this, I will not say in the detail. We have eminent chairperson and panelists. Our chairperson is Dr. Aditya Kapoor, world famed cardiologist, professor, head of department SGPGI, Department of Cardiology, Lucknow. He is a well-known intervention cardiologist and electrophysiologist, and few things I remember. I always that things like RFA, sir is the only person who is doing, or maybe a few more, and a very kind person, and believe me, whenever I need to help, we are calling him and sir is supporting me. With this, we have two my good friends, Dr. Naveen Jamwal, I think from my parallel batch, is professor of cardiology from the RML Institute, Lucknow, and one of my close junior, Akhil Sharma, maybe he's joining, and subsequently he completed DM and he's professor of cardiology in Lari Cardiology Center. For intro slide, I will not take much more time. Right now, I will hand over to Dr. Aditya Kapoor sir to introduce our speaker, sir, and for further proceeding. Thank you, sir.
Thank you, Dr. Sajid. Am I audible?
Yes, sir.
So at the outset, Dr. Anuj, he is one of the most dynamic persons I've ever seen, and very, very academically inclined. I am privileged to be part of his ACP team. And as Dr. Anuj rightly mentioned, Dr. Sajid is one of the young leading dynamic cardiologists of our area, and it is good that he is involved in echocardiography. And today, there is so much that can be said about Dr. Rakesh Gupta. You can all see the slides over there. He's so well read, so academically oriented, and the most gratifying thing is that not many of us actually venture into echocardiography to the depth that he has had. And he has had organized so many echo workshops. He has been involved in writing so many manuscripts, so many books. And sir, can I have your that slide has gone away actually. Yeah. So presently he is affiliated with Fortis Super. फिर चला गया सर. सर पीछे वाला slide देंगे. हाँ. Fortis Super Speciality Hospital. He is an adjunct professor of cardiology at Vadodara, and he has been involved in so many societies, so many memberships. I have lost count of it. And still, his dynamism, his enthusiasm to be, participating in so many programs, training people for echocardiography. I recall his training programs which he conducts, and so many books, as I mentioned, he has written. So today he is going to speak on a topic which Dr. Sajid said that he has helped choose this topic, assessing hemodynamics of the heart using echocardiography. So it promises to be a fascinating academic feast for us. We have Dr. Naveen there, Dr. Akhil will be there. So thank you, Dr. Anuj, thank you, Dr. Sajid, and of course, thanks to Dr. Rakesh Gupta, sir. And he's a personal friend as well. And thank you to the organizers for having, made us meet on this online forum. So welcome, sir, welcome. And request Dr. Rakesh to, teach us what needs to be taught about this very, very important topic.
All right. Thank you, everybody, for kind words. I said, Dr. Aditya, thank you very much. Friends are always friends, I can't forget their friendship ever in my life. Thank you, Dr. Anuj. We have met number of times before also at many other platforms, and Sajid is my youngest dynamic growing student, which I feel like he has done a lot of things in his career. I hope you can hear me.
Yes, sir.
Okay. And Dr. Jamwal and Dr. Akhil, welcome you to this session. Hopefully that it'll be something different in echocardiography, which we can utilize in our clinical practice. It's good for a physician, good for a cardiologist, good for an intensivist, good for a pulmonologist, good for critical care person in emergency and an ICU. Let's move on. The most important thing, let's look at the hemodynamics. Look, this is one cardiac cycle which we read when we were in a medical student time. I still remember 1973 when we went to the medical college, and when they talk about a cardiac cycle, we used to run away from the class altogether. And this was nothing but a closure of semilunar valves, opening of aortic valves. Then how does this diagram goes up? When is the atrial systole? When is the atrial diastole? When is the ventricular diastole? All these things we used to teach in our class time in 1973. This is today is the most important thing in our career of echocardiography. Whatever we are doing, we are just talking for. Well, all of us understand we have 4 chambers. That's right atrium, right ventricle, right atrium, left ventricle. And based on these hemodynamics, they're filling their loads, pre and after load, that happens in these substances. Let's see how do we evaluate them. That's the important thing is, We have these pressures, RA pressures, RV pressures, LA pressure, LV pressure, then cardiac output and pulmonary vascular resistance. I've taken them significantly in a fashion like we have gone from a basic with which our heart fills up, gives rise to RA pressures followed by RV systolic pressure. Let's look at the RA pressure, which is most important thing for all of us in today's circumstances. Here is a person who comes to our...
Sir, I don't know, at least I can't see your slides. Have you started the slides?
Yeah, I've started my slides.
तो साजिद आपको दिख रही है स्लाइड?
नहीं सर, स्लाइड नहीं दिख रही
सर, स्लाइड्स गायब हो गई हैं.
Okay, okay, I'll come back again. I'm sorry, I'll come back again.
So you have stopped sharing your screen, sir.
I'll come back again. Are they visible now?
अभी सर
Yeah.
स्लाइड शो
You
में
can full
नहीं आ रही.
screen.
Is that okay?
Yes, sir.
All right. This is what I was talking of a cardiac cycle in day-to-day practice. We used to talk of aortic valve, mitral valve, tricuspid valve, and pulmonic valve. And this is a basic of our echocardiography as on today. We have 4 chambers, right atrium, right ventricle, left atrium, left ventricle. And I've taken this sequence from an assessment of right atrial pressure, right ventricular systolic pressure, left atrial pressure, left ventricular systolic pressure, cardiac output, and pulmonary vascular resistance. This is the most important thing in our circumstances as on today. Here is a person whom we want to assess what is his filling pressure of the right atrium. So whether he is hypovolemic, normovolemic, or a septicemic person with absolutely normal RA pressure. So how do we do it? This is how we look at an IVC. Draw a line just attached or cursor attached to distal of our hepatic veins, and then we look at an IVC size. Normal IVC size is less than 20 millimeters. It should collapse more than 50% to talk somebody as having a normal RA pressures. Why these things are important in clinical practice? A person who comes to shock in emergency unit, we want to assess whether his volume deficit, whether his euvolumic, or his fluid overloaded. Second important thing is if is hypovolemic, we obviously give them a fluids, challenging fluids to look whether his blood pressure has become normal or abnormal. So that's how we look for RA pressure, by looking at IVC and IVC collapse. Then this gives you a mean RA pressure, very well validated in non-ventilated subject. Junction of hepatic vein to IVC in subcostal window, and that's how we look at these possible patients. This is a diagram from JS 2010. Normal IVC size less than 21, more than 50% collapse, mean RA pressure is 3 to 5. If IVC size is more than 21, collapse is more than 50%, then RA pressures are 10. If IVC size is dilated or more than 21 millimeter, collapse is less than 50%, then RA pressures are 15 millimeters. If I go on one side, less than 21, more than 50% collapse, RA pressures are 3 to 5. If I go then more than 21 millimeter of IVC size with collapse less than 50%, my RA pressures are 15 or increased RA pressure, and in between is almost 8 to 10 millimeters of mercury. And this is what universally adopted as on today in clinical practice for assessment of RA pressures. But this is valid when the patient is not on ventilator. How do we look at the patient once he's on a ventilator? That's the most important thing. And we do look at these kind of circumstances in day-to-day practice. We don't look at IVC. We look at a tricuspid inflow pattern. We look at E wave of a tricuspid valve. Then we look at a tricuspid RV free wall TDI, and then take a ratio of E wave versus E prime ratio. And it's a very simple. If this ratio is less than 10, my RA pressure is less than 10. If ratio is less than 6, my RA pressure is less than 10. If the ratio is more than 6, my RA pressures are more than 10. And this has been very well validated for ventilated subjects. Nothing of rocket science, just look at E and E prime ratio to talk about my RA pressure. It does not tell you what it is, borderline or something like that. It just tells you an answer whether we are fluid deficit or we are not. Another way of looking at IV RA pressures is we look at IVRT of right-sided tricuspid valve. If this IVRT of right-sided tricuspid valve is less than 59 millisecond, I always remember 60 millisecond. Less than 60 millisecond, my RA pressures are more than 8. If IVRT is more than 60 milliseconds, my RA pressures are less than 8. And this, if you remember my IVRT of left side also, the smaller the IVRT, more is the LA pressures. Similarly, the smaller the IVRT, more is the RA pressure. Only fact is, we don't take it a medial annulus, we take an RV free wall tissue Doppler imaging. Last, looking at the systolic forward fraction, normally what happens, we have a systolic forward fraction of pulmonic venous flow, which is more than diastolic forward fraction. What is systolic? This is systolic forward fraction. This is diastolic forward fraction. Normally, this is more than diastolic forward fraction. If it reverses, it means what? Systolic forward fraction becomes less than 55% of a diastolic forward fraction. We always look at elevated right atrial pressures. And again, very useful. Number of times we depend on these things, but the most consistent method of looking in this today's era is we look at IVC or we look for E to E prime ratio of RV free wall. Well, as the things moves over a period of time, we started talking of 3 dimensions ejection fractions. We started talking of 3 dimensions evaluations. Say, so is the IVC cross sections. By utilizing the long axis versus short axis ratio, we try to come across what is the estimated central venous pressure or RA pressure in these subset of population. Still, I'll not say that is not useful, but when we are in trouble, when we are a problem, obviously we look at these kind of issues in more. Let's move on to most important thing apart from RA is to RV systolic pressure. Well, there was a time when we never used to spend time on a right ventricle. It always used to be told as like stepmotherly treatment. But believe my words, Dr. Naveen is sitting over here, Dr. Aditya is sitting over here, Sajid, Dr. Anuj, and Akhil is joining very easily and quickly. Today, every cardiac lesion, its final outcome is dependent on what? Right? Is RV doing fine? Is RV systolic function is normal? Is RA is good or bad? Everything is dependent. And whatever we seen previously when we talk of only mitral stenosis with RV annulus diameter is no more true. Even the aortic stenosis, those patients subsequently they behave how? They all behave subsequently. The tower results of behaving over a period of time on right-sided functions. So what do we look? We look at RV systolic pressures and very simple straightforward imaging technology. Align the beam, go to a focus 4-chamber view, RV focused view, and look at the jet of a tricuspid valve, which could be mild, moderate, severe, massive or torrential. 5 definitions have come recently on this. And based on this 5 definition, what is my RV systolic pressure? And in this is what my RV systolic pressure. This slide is little old. Look, this slide has overestimated my RV systolic pressure. And how do I say like where you should measure? If you look at my beard, don't measure at the tip of a beard, measure at the chin of the beard. So somebody has measured at the tip of the beard, but we should measure at the chin of the face. And that's what the RV systolic pressure is when we are looking for RV systolic pressure. And moreover, these RV systolic pressure, they are 100% dependent on the driving force of RV. Whenever we are looking for PA pressures or pulmonary artery pressure, we should always investigate for RV systolic function. If that is hypokinetic, this will be also underestimated. Looking at all these things, what do we get? We get pulmonary artery pressure, that's peak pulmonary artery pressure. ER jet velocity, going to Bernoulli's equation, will get a gradient. Add RA pressure by IVC or E2 prime ratio, that will give you peak pulmonary artery pressure. In our place, we always say we should assess RV systolic pressure in 5 different windows. Wherever the maximum is, we should write that this is the maximum RA pressure, PA pressures are seen, and this is the window where it is seen. In one of our own study in our center, we looked at these kind of things. And you know what was the important thing? It was found most commonly in RV focused view. Then second was subcostal window, very amazing. And third came RV RA inflow view. And last came this parasol long axis view and the apical four chamber view. And majority of us, they spend time in looking at apical four chamber view. But take my word, if we look at an RV RA focused view, that is the most common window where we do assess. And subcostal window was very useful in people who are having a chronic obstructive lung diseases. Then what is peak pulmonary artery pressure? Less than 28 plus RA pressure, up to 40, mildly elevated, moderately elevated, severely. But this definition no more holds true, because whenever we talk of pulmonary artery pressure, we always talk of a mean pulmonary artery pressure. Anything less than 25 is considered normal. Elevated more than 25 is considered as elevated, mildly, moderately, or severely. Now, this definition varies a little bit from place to place, book and person to person. But important thing is, when do I say that possibly the RA pressure, the PA pressures are elevated? You look at a TR jet velocity. In case of a normal RV systolic function, if my TR jet velocity is 3 meters per second, start thinking that possibly RV systolic pressure, pulmonary artery mean pressure may be higher, as depicted in the slide. It says 2.9 to 3.4, presence of possibly pulmonary artery. So cutoff is roughly 3. That's how we remember in our lab. How to get the mean pulmonary artery pressure from a peak? This is here is, we got the peak pulmonary artery pressure from TR jet velocity, thinking that RV systolic function is normal. This is almost 78 millimeters of mercury. I took it as 80, added RA pressure as 10, 90 into 0.6 plus 2.1, that is 56 millimeters of mercury mean. So any TR jet, you add RA pressures to it, get in a value, multiply by 0.6, add 2.1, that gives you mean pulmonary artery pressure. And if I go back to my slide previously, in this slide itself, it's tell you like the mean pulmonary artery pressure is severely elevated. And that's how we look at these mean pulmonary artery pressure. Many people, all of us also, we use number of times this Mahan's equation is, I'm sorry, we don't use in our lab. Anytime, majority of time, we'll try to dispense it with. Why? I'll say a couple of minutes. This acceleration time is dependent on heart rate to a very large extent. As the tachycardia develops, so is the diastole as the systole gets truncated, and this acceleration time becomes shorter and shorter and shorter. And this acceleration time is 80 minus half of acceleration times gives you mean pulmonary artery pressure. This is a good method of looking at it, provided what we say in our lab is, provided my heart rate is 60 to 70, I would like to depend on this. Otherwise, definitely not. I look for other things to talk about. Next comes, you can have a raised pulmonary artery pressure, but you may not have a good gradients. And a very other answers is when RV-RA, they keeps on dilating and dilating. So that non-cooptation of tricuspid valve happens. What happens after that? Look at this tongue-shaped pattern gradually becomes dragger shape and finally bifid dragger shape. And once you see this dragger shape pattern, whether the gradients are there or not there, you always think of severe pulmonary artery hypertension. And that's what the very important take-home message is. And why I look at RV systolic pressure, take my words, every cardiomyopathy, every heart failure with preserved ejection fraction, every valvular lesion, everything on the left side, if you look at the right side, you find many other things apart from right side per se, whether it's a pulmonary embolism, ILD, chronic obstructive lung disease, anything on the right side, we have to look for these pulmonary artery pressures in every patient in day-to-day practice. Just want to correct one thing. This paper was published something in 2009, JACE. What exactly they did was they started looking at tracing the envelope of a peak pulmonary TR jet velocity and saying why we can't get a peak and mean velocity gradients in this. We did utilize in this our lab. We studied for almost 120 patients, but in this method, we were overestimating RPA pressures by echocardiography. Look, we cannot, ultimately the gold standard is, of course, cardiac catheterization. But when we looked at two different methods, we always found that looking at a peak TR jet velocity and then calculating the gradient was much more accurate than tracing this Doppler envelope. So we dispensed this away, and that's why I showed this slide. Like, we used it for some time, but gradually over a period of time, majority of people all over India and internationally, they still do not adopt this particular method, will utilize peak TR jet velocity gradient for calculating mean pulmonary artery pressures. Last but not the least, and very, very useful thing which we see in our lab today, we look at a PR jet gradients, early diastolic, late diastolic. Peak of early diastolic gradient, if you add RA pressure to it, they'll give you a very good idea about mean pulmonary artery pressures. And that's what, when we have a good PR jet Doppler flow pattern. And this we found again to be very, very useful in our clinical practice, where instead of using a Mahan's equation, we were able to use this particular equation for calculating mean pulmonary artery pressures. Last, if we have a ventricular septal defects, we can look at a RV, RA systolic. We look at a pressures between LV-RV, and LV pressures are always available with us in the absence of aortic stenosis, and that is systolic blood pressure. If we detect that systolic blood pressure and this pressure from a systolic blood pressure, we'll get a pulmonary artery peak pressures. And here is an example where we have a patient with mid-muscular VSD. We can see in both the windows, both in plaque, both in other in short axis window. And here is a peak jet velocity. This is almost 45 millimeters of mercury. If this baby's blood pressure is 70 minus 45, that will give us about 25 millimeters of TR jet velocity. Again, very well correlated if my angle is almost parallel to the direction of flow of a jet. So that's how we look at RA pressure, that's how we look at RV system. Now the most important thing is LA pressure. Any person, hypertension, diabetes, obesity, sleep apnea syndrome, then aging population, hypothyroidism, what we need to look today is we need to look at an LA pressures. And how do we look at an LA pressures? We look at EA ratio of a mitral Doppler flow. Then we look at E prime septal of a tissue Doppler. Then we look for E prime lateral of the tissue Doppler. Then get an E to E prime average ratio and then look at a TR jet along with LA volumes. Once we look at all these five things together, we can put a graph or put on this particular table what kind of a diastolic function we are dealing with. In this, we are having an EA ratio of 1.13. So it classifies either in normal or grade 2. E to E prime ratio 22.3, obviously classified to at least grade 2. Peak TR jet velocity more than 2.8 and LA volume index is 57.2 ml per meter square area. So these four parameters, they classify to grade 2 and with raised LA volumes. And how does it transforms to the LA pressure? And here is a picture which tells you like normal grade 1, grade 2, grade 3 or 4 diastolic dysfunction transforms to LA pressure of normal about 8 to 10. Grade 1, which is very commonly seen in elderly population, more than 10, not of a significant value. But we start having a grade 2 diastolic dysfunction, the LA pressure has started building up. What does this mean by LA pressure? This is preload is building up. And that's my personal, I may not, like many people, they may not subscribe to my thought, my processes. Any person who's having a non-valvular atrial fibrillation, he initially develops or she initially develops the raised LA pressure. And these raised LA pressure, they put a pressure on the pulmonic veins. And when they put a pressure on pulmonic veins, what will happen? They get stretched and the patient develops an atrial fibrillation. So why it's important? Like many people, they come to us, especially diabetic hypertensive, they are breathless. They're breathless in walking for a certain distance. We get them an angiogram done. We get them a stress echo done, but normal. We look at the lungs by lung function test and CT lungs. Again, normal. We have to look at these subset of population looking for raised LA pressure. And what is the answer? Nothing very large thing. Just we need an ACE inhibitor with diuretics to reduce their preloads. And maybe at one time, like we start talking of this, like we should have something like a preventive study where all these people are hypertensive diabetics, if they are given us some amount of ACE inhibitor with diuretics, when they start building up their LA pressure, maybe to some extent people can be prevented from going from non-valvular atrial fibrillation. That's what my thought is. Maybe I'm wrong, I'm right, I'm not really sure, but I'm not that level to do this kind of a work. But certainly, this is very good modality in our country where we should utilize this doing an LA function in practically everybody. That was with preserved ejection fraction or normal ejection fraction. But when we look at a reduced ejection fraction, we have to look at these with ischemic cardiomyopathy, dilated cardiomyopathy. We have to look at all these kind of a partial population, because even those also we have to optimize their drug therapy of ACE inhibitor with diuretics. And how do we look at? We again look at EA ratio, E to E prime ratio, then look at E to E prime average, TR jet velocity, LA volume, almost the same kind of a things. And based on this, we tell them as grade 1 diastolic dysfunction, grade 2 diastolic dysfunction, or grade 3 diastolic dysfunction. And if very important thing, if EA ratio in reduced ejection fraction is more than 2, it means my diastolic function is grade 3. My LA pressures are already built up more than 15 millimeters of mercury. Same thing we do separately in atrial fibrillation, sinus tachycardia, and hypertrophic cardiomyopathy, restrictive and non-cardiac pulmonary hypertension. Obviously, in mitral stenosis, mitral regurgitation, the parameters are little different. And when we use this parameter in day-to-day practice, obviously they'll be good. It's good for a cardiologist level, good for a level 2, level 3 people, but not really good for physicians level to begin with. To begin with the physician level is remember this chart and remember this chart. That's more than enough for all of you who are attending this. This is one diagram like I drew number of times, is how does the abnormal relaxation goes to pseudo-normal, then reversible, and finally the irreversible pattern, where I still remember a very leading tertiary cardiologist at Mayo Clinic, Rochester, when I was working with him, Jim Seward. Jim Seward always used to say, Rakesh, if somebody goes to grade 4 diastolic dysfunction, it means his train for mortuary has left. Is only a matter of time when it reaches over there. And this is true, no doubt about it. I remember a very important thing, a lady about 5 feet in my height and had a grade 4 diastolic dysfunction with almost normal systolic function. She was referred to me for a preoperative evaluation for lap chole. I said, no, she should not undergo a lap cholecystectomy. Surgeon, very enthusiastic. He said, nothing doing. Anesthetist, equally enthusiastic. Look, his ejection fraction is 60. How can you say she cannot do it? And believe my word, she went for a lap chole and did not come back. She could not be taken off the ventilator subsequently because elevated pressure was so much that they were absolutely non-reversible. And one point which can really make a difference between restrictive versus non-reversible is look at tissue Doppler imaging of posterior annulus. Posterior annulus, EM velocity is less than 4 centimeters per second. Take my word, his or her elevated pressures are more than 25, non-reversible. So let's move further. LV systolic pressure. Well, this is a thing which I always say when I teach in my resident, when I'm in CCU, when in ICU. Sister always tell you, doc, your blood pressure is, you ask the sister blood pressure. There are two things are very common in every hospital. Blood pressure is 120 by 80, heart rate is always 80. Whether patient is hypertensive, whether patient is hypotensive. And if you have this particular phenomena in your echo lab, in ICU or a CCU, what you have to do? Nothing. Just put a cursor across this try mitral regurgitation. And as soon as you put a cursor into mitral regurgitation, you will get a gradient. Look at the gradient is almost 80 millimeters of mercury. Velocity is almost 5 meters per second. I always tell to my resident, if my velocity is less than 5 meters per second, take my word, the patient is in shock. He said, boss, less than 5, shock? I said, yes. If the velocity is less than 5 meters per second, it means 5 into 5 into 4 is less than 100 millimeter of systolic blood pressure. Am I right or wrong? And if you add RA pressure to it, it means it will be further less. So this tells you a significant amount of MR jet. How much is my driving force from LV to LA? And LA has got some inherent pressure. If this is 780, if LA pressures are 10, my systolic blood pressure is 90 millimeters of mercury. So that's how we look at LV systolic pressure. Only fact is there should not be any obstructive lesion subsequently, neither no aortic stenosis or no aorta stenosis. That should not be there to talk of this LV systolic function. And I use it very often everywhere, very often at number of places. Even to a large extent, when I'm doing a kid's echo, I'll try to look at, because majority of kids are able to find a tiny MR jet velocities, tiny MR jet. And you put a cursor across tiny MR jet, it'll give you a very good, what is the systolic blood pressure of these babies, because babies do not have a raised LA pressure. Babies' pressures, LA pressures are hardly 0, 3, 5. So that gives you a very good idea what is my pressure of my baby. I don't need a cuff for my babies. So I don't have to look at sizes of the cuff of my baby to calculate their blood pressures. Moving further, once we do on my LV pressure, the most important part of our life is to look at. Many friends tell me, Rakesh, your report always talk of a cardiac output. I said, never always. I always report cardiac output in those patients who are having what? Who are having dilated ischemic cardiomyopathies. Once these people, they come back again, we always look at LVOT VTI or aortic valve VTI. We look at an LVOT diameter. Looking at LVOT diameter, pi r square of LVOT diameter into LVOT VTI will give us a cardiac output. And when these people, they subsequently come up for follow-up, we always look at their LVOT flow velocity or VTI. If their VTI has gone up, previously it was normally is about 20 to 25, and once it's gone up, like previously it was 19 or 14 or 15, now it has become 18 or 20, it means their LV is contracting better. That's how we always look at this cardiac output, especially aortic or LVOT VTI, whatever you want to do in the absence of any aortic lesions. So that's how we calculate it. LVOT diameter divided by 2 will give us radius, multiplied by square of that radius, 3.4 into LVOT VTI, and that's how we get a stroke volume. Stroke volume multiplied by heart rate, we get the cardiac output. And this is same sequence which we utilize in aortic valve area for continuity equation. This is what we utilize for LVOT, and that we divide this stroke volume by aortic valve VTI, we get aortic valve area in day-to-day practice. Last is pulmonary vascular resistance. We often calculate this pulmonary vascular resistance when we have some issues going on the pediatric population or patient presenting with lung fibrosis or some lung conditions. And it's not a very difficult scenario. Is pulmonary vascular resistance by echo is 10 into tricuspid regurgitant velocity oblique RVOT VTI. Here's a TR jet velocity of 2.4, RVOT VTI of 15.5 centimeter, 10 into 2.4, 15.5. Now, the most important point at this point is we have to keep this TR velocity at meters per second, and this is in centimeters per second. And what we get is Wood's unit, 1.66 Wood's unit. And in this case of pulmonary fibrosis, you can see that this is almost 4.8 Wood's unit. So that's how we tell people, like, despite many things in life, we can really tell our physician, look, he is already having a significant pulmonary fibrosis. And believe my words, like I can say on this platform, when the people, they were coming back from COVID and they were not responding to many treatment, and I was calculating the this pulmonic vascular resistance. It really helped me in telling those people, look, their lungs are getting involved over a period of time. And many of the people, I don't know how, I have no answer for all, because COVID itself is, I say, what do you say, like, is a new entity where all of us are learning over a period of time. Some people, they progress this Woods unit, become from 5 to 4 to 5. Some people, their Woods unit reduce over a period of time and they become symptomatically better. So that helps us in really concentrating more on this population of. So in turn, in last, I can say we can look at a cardiac pressure, RA approximately 3, RV approximately 25, LA 5 to 8, and left ventricular is almost 100 millimeters of mercury, with which you can evaluate in day-to-day practice. And some people, they utilize LV systolic pressure go in a reverse direction. I've deliberately not used LV systolic pressure. Only by echocardiography, I was trying. Thank you very much. And I'm grateful for a patient's hearing, and grateful to each and every one of you, including Dr. Naveen, Dr. Akhil, Dr. Sajid, Dr. Anuj, and one of my very good friend, Dr. Aditya, for patiently listening. Thank you very much.
Sir, thank you so much. Dr. Sajid, can I start with making few comments?
Yes, sir. Sure, sir. Sir, you start, sir.
Sir, absolutely fantastic. I mean, I was totally mesmerized, and it just shows that there is so much to learn in echocardiography, and you should choose the right person from whom you learn. And it was totally captivating. And in fact, I was trying to take some notes also, but so it was really very nice, and I hope everybody has benefited. So just to revise, what you said and what I actually learned from it. First of all, you mentioned about looking quickly at the IVC, which will give us an idea about the volume status of the patient. So that is one thing which you said, that is a very quick thing to do. You mentioned briefly about the systolic flow fraction also, and assessing the pulmonary artery pressures. You mentioned, sir, about the 4 parameters of LA function. So just for the, educating the audience once again, you mentioned about the pulse. Yeah, if you can have the slides again. Pulse velocity you mentioned the, medial wall and the septal and the lateral TDI and the LAVI, left atrial volume index. So just briefly, if you can just educate us once more about it, because we also have been using LAVI very commonly. So just briefly tell us that, what are the cutoffs for LAVI, and how exactly do you measure LAVI? Because people used to do 3D as well, but now we know that 2D is as good as 3D for estimating the LAVI. So one thing is about the LAVI, and secondly, I really was fascinated about what you said, measuring LA function and LAVI in patients of diabetes or patients who come with unexplained shortness of breath, because sometimes we don't pay much attention to it, and as you rightly said, they undergo an angiogram. So the thing about the left atrial function and the MR jet, which you explained, that was again a very, very fascinating data, that how can you estimate the pressure from the MR jet. So just briefly, revise that for us.
Yeah, just give me a second, Dr. Aditya. This is like heart failure. Just give me a second. I'm opening up that slide of my diastolic heart failure. It'll take a few seconds. And in that, I've categorically utilized all these in practice.
Because, these are so important things. And as Dr. Sajid, Dr. Naveen, Dr. Akhil will vouch that many a time, in a busy echo lab, our residents will miss it. We also miss it. So the more number of times we hear it from a master, the more number of times it will retain in our memory. And actually, by the time sir slides are opening, we did a thesis of, LAVI to predict outcomes in patients of ACS. So it's again a very, very useful concept. Should be used more.
Here is, I hope you can see my slides now.
Yes, sir.
So this is 4-chamber view. This is 2-chamber view. We take these views together at the same time in same QRS cycle. Look, we can see at the end of systole, at the end of systole in both the things, and try to get the maximum size of both LA in 4-chamber as well as 2-chamber view. Then as we trace the LV, we trace from medial annulus in 4-chamber view, go around all the round and come back to lateral annulus and leave the cursor, will join automatically. Same we do on the left-hand side, two-chamber view. We trace the area and then look at these two areas. Wherever the shorter area is, we take a shorter of these two lengths. And machine gives you automatically 0.85 into area 1 into area 2 divided by short of these two lengths will give you LA volumes. If you divide these LA volumes by body surface area, machine will always feed height, weight, body gets a body surface area. Anything more than 34 cc per meter body surface area is considered as elevated. And I can show you one slide which I'm always fascinated in showing in multiple platforms, and that's not today's one. It is published in JACE 2013. Very interesting. And what exactly they said, if you look at this slide of JACE 2013, this says LA volume index per se is a surrogate marker for significant cardiovascular disease. I hope I'm able to get this slide. And this is what is very, very like dogmatic statement in 2013 coming from JACE itself.
So I think, as you rightly say, it is even a better predictor of adverse outcomes than global
Correct.
action.
Exactly, because we hardly spend time on a global ejection fraction. Like today, if somebody asks us what is ejection fraction, I always say, man, leave the ejection fraction. We have so many things to do apart from ejection fraction. So I'm just trying to the slide of 2013. Yeah, it is here. This is left atrial volume index relation to long-term clinical outcome in type 2 diabetes. Objective was to prognostic importance of LA dilatation in patients with type 2 diabetes with no history of cardiovascular disease. Background is type 2 diabetes associated development of cardiovascular disease and morphological changes on the heart may appear before symptom arises. You know what is said in conclusion in JAC 2013? Increased LA volume index was independent and incremental predictor of cardiovascular mortality and morbidity in type 2 diabetes with absolutely no history of cardiovascular disease.
Yes, I think
we utilize this particular thing in our lab. Two things we are utilizing in our lab today. Any person walking with diabetes will always try to do a GLS, stage heart failure. We'll tell you, look, this guy is getting to stage B heart failure. Or raised LA volume. If his raised LA volume is, we are the first one to add ACE inhibitor with diuretic, despite their normal blood pressure. So this is one study like, look, I'm not a big institution. You people are a big institution working over there. This is one place where we can contribute to our country from saving from onslaught of a diabetes mellitus, going these people into heart failure with preserved ejection fraction, and maybe subsequently with non-valvular atrial fibrillations.
Yeah, because I totally agree that LAVI is such an important and underutilized thing, because when we analyze our own data, we found that in patients undergoing coronary procedures, it was a wonderful predictor of outcomes independent of ejection fraction.
Absolutely, absolutely. These are filling pressures.
Dr. Naveen, Dr. Sajid, any questions?
Yeah,
Because we can have more
thank you,
questions.
sir. Thank you, sir. I think this was really mesmerizing, sir. Sir, we have learned a lot of things while using, sir, RF pressure. I mean, till now, I am not using this TDI of this tricuspid annulus to calculate RF pressure. Using this IVC collapsibility and so and so, sir. So, I mean, is it equally effective, sir? Because in my practice, very honestly, I am not using this right-sided TDI on the tricuspid valve.
So, Sajid, which car are you using every day?
Yes, sir. Because when I was doing fellowship with you, this was not in the great discussion. That's why
no, you did not answer my question, man.
Yes, sir. It is changing. Yeah.
You have moved from Maruti 800 now to Honda City, and you're still not using TDI.
No, sir, using TDI for the left side, for the, I mean, right side, yes, sir.
You must use TDI for the right side also.
Okay, sir.
It's very simple.
Yes,
sir. Lateral annulus TDI, you should come to the right RV free wall TDI.
Yes, sir. One small question again, sir. What's the correlation of LAVI with age, sir? Is it true that while advancing the age, left atrial index volume is increasing?
That's what I was discussing with saying a few minutes back. We must look at this in diabetes, hypertension, sleep apnea syndrome, obesity, hypothyroidism, and aging population. We can correct 5 except aging population.
Yes.
My words, if we correct in these 5 populations, and last I would add one more, which is seen recently, CKD also. We find lot many people coming with CKD with a raised LA volume index. We correct these population. God can correct the aging. We can't correct the aging. That's not in our hand. But rest 5 or 6 we can correct definitely. And they keep on increasing as the disease progresses.
Thank you, sir. Thank you. Over to Dr. Naveen and Dr. Akhil, please. Dr. Naveen and Akhil, please have a comments.
Thank you, Dr. Akesh. It was a wonderful presentation. Very exhaustive, very informative, invigorating. There are certain things which have, as Aditya sir was saying, that we have not actually heard about. And like I think he also requested, I request you, sir, if you can tell us about that MR jet and how you use it for the LV pressures. So that is actually something new for me also. I've not heard about.
You know, like even I learned so many things in emergency room only, CC only.
Right.
When I was doing echo for acute MI in emergency room, and my sister tells me, sir, blood pressure is 120/80. And I was hardly able to get an MR jet. With jet velocity. MR is huge, like it's wide open. You can see a severe MR, but jet velocity is hardly in. I said, no, the blood pressure patient is in shock.
Lower jet velocity will correlate with the lower pressure.
Yeah, lower pressures, very straightforward. And in fact, as the problem will rise, acute MIs and another patient is, my LA pressure also keeps on building.
Definitely. I think our residents can use this modality. I mean, probably.
I think Dr. Naveen is absolutely right, because it was taught in the past, but again got left out. But again, it has been revised and reiterated today. And as sir rightly mentioned about the RV free wall TDI, it's a very good marker in ventilated patients, Dr. Rakesh told us. So again, that's a very good clue to remember. Sir, there is a question in the chat box. Dr. Naveen, can you see the question? Because in chat box, the question is circulating.
Yes, sir. I can hear. Sir, I'll repeat it for sir. So in transmitral Doppler study, what is the basic difference between E and A wave merged versus E and A wave separately placed? E and A wave merged versus E and A waves.
Yeah, correct. I can answer that question very easily. But what he says is, you look at a transmitral wave. If the E and A are there merged, it means that tachycardia is going on. And at that time, if your tachycardia is going on, you ask the patient to hold his breath. His heart rate will drop. Or you wait for a beat which comes after a ectopic beat where E and A will separate. And otherwise, you can go for, I can go back to my slides again. I'll just give me a second. I'll go back to my slides, previous slides. In those slides also, you can calculate your LA pressures in tachycardia. There's a different way of calculating LA pressure in tachycardia in special situation. Now this is a slide you can see. I hope you can see the slides. If my sinus tachycardia is present, I'll not put more emphasis on this EA ratio. What I'll do, I look at an IVRT and then look for E2 prime average. If E2 prime average is more than 14 and my IVRT is less than 17, my LA pressure is elevated. And that's what exactly he said. EA velocity partly confused, partly fused, presence of compensatory period after premature. EA separation can be used for assessment of diastolic functions. From our lab, believe my words, every patient will get out from a lab with a correct assessment of a diastolic function based on normal ejection fraction, reduced ejection fraction, atrial fibrillation, sinus tachycardia, hypertrophic cardiomyopathy, MS, MR, non-pulmonary hypertension. Everyone will have a separate evaluations. And it really helps. If
Yeah.
I'm doing a patient's practice, believe me, it really helped me. I can quote a person came from a CDUC diabetic center. The lady was having persistent tachycardia and dyspnea on exertion. She was prescribed beta blocker, her dyspnea got aggravated. Angio normal, CT normal, lung function test normal. What we did a stress echo. LV function was normal, but she had a dynamic diastolic dysfunction. Despite normal everything, we added ACE inhibitors, initially with diuretics, and she came after 3 months, tachycardia, everything disappeared. She was not dyspneic later on. She was not having tachycardia. And now LS chain is available today. With a passive leg raising test in looking forward for dynamic diastolic. Just passively raise the legs. You'll find the change in echo pattern of a mitral flow pattern. You'll get a dynamic diastolic dysfunctions.
I think that's extending echo to sort of treat these patients who are otherwise often not only missed but mistreated as well. Is Dr. Akhil there? No. Can I ask one more question, Dr. Sajid? We still have
Sure,
time.
sir. Welcome, sir.
Dr. Rakesh, ये बताइए, because sometimes we get these patients of low flow, low gradient aortic stenosis, and I think diagnosing them correctly again is a challenge. So what is your approach to these patients? Because sometimes these patients come in clinical practice, and as you rightly said, when the LV is down and it cannot generate a gradient. So I'm sure you have some wise words for us about that as well. That is a very, very important.
There are two kinds of a low flow, low gradient aortic stenosis. One is a truly lower ejection fractions. Obviously, we give them a dopamine. Everybody knows about it. Second is low flow, low gradient paradoxical aortic stenosis, where LV function is normal, but there's a discrepancy between gradients and a flow. That's what exactly the answer is. We always look at these people by looking at their GLS. If their GLS is low, we are very sure about it that these people should undergo a aortic valve replacement. And that's how we have been doing in our, and as you must be knowing, like these people, they behave the worst amongst all the class of aortic stenosis. And I was discussing all these things, fortunately, unfortunately, only 2 days down the line. I was taking a DM cardiology class along with Dr. Dayasagar Rao, Dr. Sanjay Tyagi, the CSI master class on Sunday. And we were discussing all these things, like where the involver lesions, how we can really assess these kind of things. So GLS is one important thing which really makes a difference. Let me just unearth that slide. Give me a second. It'll just give me 1 minute time. I'll be able to show that slide. And that makes a lot of difference today in a clinical practice. Looking at the GLS, and we can tell them their GLS is low. They are the people who needs valve.
Sir, meantime, can I put some question for my knowledge, sir?
Go ahead.
Yeah. Sir, this low flow, low gradient, but severe aortic stenosis. Why did this aortic valve look heavily calcified and things not opening? In that condition, my clinical interpretation is patient having severe aortic stenosis, but gradient is not coming. Is it justifiable to go for dobutamine stress echo in that kind of situation?
No. Sajid, low flow, low gradient aortic stenosis is of two types. One is with preserved ejection fraction, and second is with reduced ejection fraction.
Yeah.
If it's a preserved ejection fraction, that's only we talking of a paradoxical aortic stenosis. If it's a reduced ejection fraction, we give them a dobutamine to look whether this thing is increasing or decreasing. So we are talking of this paradoxical one. We are not talking of the other one. Other one, everybody knows about it. Look, this is one is where we have to give dobutamine echo. If with dobutamine echo, his gradient goes up and the area reduces by continuity equation, then it's true. Otherwise, it's a pseudo one.
Okay, sir.
And what we are talking is, we are talking the other one. We are talking of can you see my slides now?
No, sir. Still it
No.
is LA pressure. It is not
Okay,
general.
okay. I'll come back to stop my and then aortic stenosis. So this is what you were talking of: low flow, low gradient aortic stenosis. Paradoxical aortic stenosis with more than 50% ejection fractions. And what you were talking is when we have a poor ejection fraction. We are not discussing that. In this subset of classification, if we have a low flow, low gradient aortic stenosis, then we look at the most controversial and the worst outcome of these subset of population: smaller diastolic cavity, reduced longitudinal systolic function, restrictive filling pattern, high BNP, lower arterial compliance, higher arterial and valvular loadings. And we always do GLS, and whenever the GLS is poor, obviously we take up these people for interventions.
I am glad you showed this slide because this paradoxical low flow, low gradient is in fact, as you rightly said, associated with more adverse outcomes.
Very high mortality, very high mortality.
A brief word, to educate everybody also, because initially sometimes we used to calculate this valvulo-arterial impedance ZVA value also in these patients.
Right, absolutely true.
So again, that is a good parameter to calculate. I'm sure you have that slide somewhere because these are very, very sick patients. So it's just a very simple way to calculate systolic.
In fact, in JAC 2019 imaging, the whole journal was devoted on this aortic stenosis.
Oh, wow. Okay.
This is what the JAC imaging 2019 journal. Total journal is devoted on aortic stenosis.
Okay, great. Wonderful.
Like this is one severe aortic stenosis, EF67, GLS 9. Same patient, GLS 12.
So again, calculating GLS in these patients will be very,
very useful. Very useful. This is another slide from the same JAC journal. Ejection fraction less than 50, GLS.
Yeah, this was that paper. Yes.
Follow-up is worst, like.
Wonderful. Dr. Sajid, any more questions, sir?
I think sir has covered, so many things, and question is going on because सर मास्टर हैं तो हम शिष्यों की जिज्ञासा तो बनी रहेगी सवाल करने की।
कोई भी साजिद मास्टर नहीं होता, जिस दिन वो अपने आप को मास्टर समझ लेता है उस दिन वो बेकार हो जाता है।
Sir, one thing, even I read in your fellowship class also, while dividing the gradient of diastolic dysfunction, grading 1, 2, 3, we are calculating this pulmonary venous flow velocity. But while grading 1, 2, 3, usually that is not incorporated in that table, sir. Systolic and is it also?
Reason is like we are graduating, over a period of time, we are moving to further. The Sharif Nage published his classification and he started improving them. But believe my word, when we are stuck, where we are going back? We are going back to IVRT. We are going back to pulmonic flow.
Okay, sir.
Then Dr. Jamwal and everybody will agree with me. The number of time we get stuck, what kind of a diastolic dysfunction is, we go back to old parameters. Valsalva, leg raising test. And now new modalities, I don't know how far it will be useful, but LS10 gives you a lot of information for reservoir values.
Thank you, sir. I think Dr. Anuj sir is here. Please, Dr. Jamwal or Akhil, any comments further? Over to Dr. Anuj sir.
Well, sir, I think sir has covered almost everything and answered to most of our queries. I think this has been a very informative talk for all of us, including me. This kind of in-depth knowledge of echo, I think we never had. And, especially after being part of more of intervention these days, we are getting a little away from this kind of interesting echo pathology.
Dr. Jamwal, if you allow me to say one word, in CSI master class, for 1.5 hour case discussion, the echo was given only 1 minute.
Yeah, that's unfortunate, sir.
And all 5 examiners, unfortunately, I've told you all the names, all 5 examiners, they rushed through echocardiography.
That's very true, sir. Similarly, sir, residents also, I think the focus, when we were doing our DM and the DM that we are imparting to our residents, I think Adit sir will agree that we had more focus on echocardiography. That focus has definitely decreased because of intervention and all.
And I believe this is one modality which is a need of the hour. Look, we are not looking for secondary outcomes. Let's look for primary outcomes.
Yeah, I agree with you, sir.
Absolutely. Absolutely.
I think Dr. Anuj sir is here.
You can conclude, Sajid. You are
No, boss.
only.
No, sir. Till he will join, I have one more question. I mentioned in sir, while calculating the gradient of VSD, you show your diagram. Sir, you was using this plex view, and what we are doing, I'm making short axis view for the better flow of the VSD gradient.
A view is not important. Alignment of a jet is important.
Okay, sir. Yeah,
How parallel you are to the flow. I'm hardly bothered about the view. I will try to get that jet aligned parallel with the Doppler flow.
Yes, sir. So that, because while calculating, I'm using parallel short axis view. That's why. Dr. Kapoor, sir, any final comments from your side, sir?
Yes, Dr. Rakesh, I think this lecture has been so good, and I think we'll continue to have questions for him, but it has been a very, very important thing. And as Dr. Rakesh rightly said, this technique has to be sort of pushed more into DM and DNB cardiology programs. So that is the problem, that nowadays, as he rightly said, we focus so much on, extraneous things, and then as the echo comes, we just, jump on to some other investigations. So I think that is an important thing, and hopefully such classes will, generate the interest more. And as ACP has done today, and as Dr. Sajid is himself doing, if people are more interested in doing echocardiography, then this investigation will find its rightful place.
Thank you, sir. Thank you. And Dr. Anuj sir has joined it. Yeah, please over to Dr. Anuj Maheshwari, sir, for final comments. Yes.
I think when so much of the stalwarts are there, there is no need of any final comment. Only I can say finally, thanks to all of you. Thanks to for joining the ACP program. Thanks for coming on the forum of the American College of Physicians India Chapter, and graced with your presence and your with us. And that is a great thing for American College of Physicians. I convey my thanks, heartiest thanks to all of you. Thank you very much.
Thank you. Thank you, everybody.
Thank you,
Good
boss.
night.
Thank you.
Thank you, everybody.
Thank you.
Thanks to everyone, all seniors and friends, and Governor Acp India Chapter for giving this opportunity. We will meet soon in coming days. Thank you, sir. Bye-bye.
Good night. Shabbat
Good night. Shabbat.
Thank you. Bye.